we'll get started right now. Thanks again for joining us. The title of today's brown bag is Copay Caps and how they aren't the final solution. We do these monthly events to dive into a policy topic head on and really cover it for half an hour. So thanks for joining us on your lunch break. We hope you brought your lunch. Feel free to eat it. We cannot see you. And I'm going to introduce George Huntley, who is going to walk us through today's slides. George is the CEO of the Diabetes Patient Advocacy Coalition, as well as our affiliate organization, the Diabetes Leadership Council. George has had diabetes for almost 40 years, type 1. He is the past national chair of the American Diabetes Association. And George, I will let you take it from here.
Well, thank you, Julie, and good afternoon, everybody. I think it's officially afternoon. It's a pleasure to be with you. We'll talk through about why copay caps are great, but how they're not the final solution. So once I get the slides to move forward, there we go. So a little bit about Deepak and our mission, which is to ensure quality of access to care, medications, devices for patients living with diabetes. It's first and foremost. And the second is to educate, inspire, and to empower patient advocates like hopefully everybody on this call and everybody on the Facebook Live, as well as lawmakers to help make meaningful action on access and care for people with diabetes. So we're glad you're with us. Deepak is proudly affiliated with the Diabetes Leadership Council. And full disclosure, I'm CEO of both organizations. The Diabetes Leadership Council is a policy shop. Everybody on that board is a past leader of a national diabetes organization, and we focus just on policy issues. Deepak is the grassroots army with thousands of advocates across the country. These organizations are affiliated, but they have separate boards, separate staff with a little bit of cross-pollination to make things work efficiently. And I've never really thought of myself as a pollination, but I guess I am today. Hope you all are get to know us and be part of the Deepak Nation, the Deepak Army. Deepak is in every state across the union. So we've got grassroots advocates everywhere. This is baseball season, so hopefully you like the baseball cards idea. We collect as many as we can because we need as many advocates as we can, and we really appreciate all of the Deepak champions and advocates across the country. Quick housekeeping notes. This is being recorded on Facebook Live. So if you want to catch it again, please watch it again, but please also share it with your friends who might think who may have missed it, that you may think might be interested in seeing it. If you have any questions, there's a Q&A section at the bottom of the screen. So please type in any of those questions in the Q&A and we'll try to get to those during the session. If there's any technical difficulties, please put those there as well. And we'll see what we can do about that. Will be a quick survey afterwards. So please do that and fill that in and let us know how we're doing. And we appreciate any feedback you give us, good or bad. And enjoy. So I think you all know where the restrooms are. So if you need those, find them yourselves. And without further ado, let's get in. So first things first, why are we talking about copay caps? Oops, I went the wrong way. I should have had Jacob do this. My hand hit the wrong button. Hate that. First things first, why are we talking about state copay caps? And the answer is because we haven't gotten to the point where diabetes care is preventive coverage in the US yet. Medications, devices, all the things that we need so the pancreas, can be accounted for, if you will. We're not there yet. So preventive coverage, for those that don't necessarily understand what that means, is where we bypass the deductible. You're in a high deductible health plan, and if it's preventive coverage, then you don't have to wait till you hit your deductible until the diabetes care items are starting to be covered. And that is the ultimate item we're trying to get to here, so that nobody is faced with list price. You're going right to a copay. You're going right to, ideally, zero cost share on things for chronic disease, especially for diabetes. So you look at $334 list, a $50 cap. $50 cap is a much better place to be if we don't have these other two things in place. So let's start with the basics of what does a state copay cap do. So it maximizes the out-of-pocket which sets a maximum out-of-pocket cost for patients at point of sale. So again, $50. We're going to talk a little bit about the differences in some of these areas. And it's for patients enrolled in state-regulated plans. So they will only pay a certain amount for their monthly supply of insulin. Now, you say, where did all this come from? Because we've started these state caps and it's now starting to be a hot topic, hence we're covering it today. It started in 2019 in Colorado. So this fairly new wave of legislation coming across the country here. A couple things. I mean, we're going to see in a second, there's 15 of them already passed. It is very normal for things to start at the state level and then just go through state by state by state. One thing I would say here is this started in Colorado. Wherever you are, wherever you're advocating from, you can make a difference, and that difference can become national. It doesn't have to start in New York or California. It doesn't have to start in Washington, D.C. We can make a difference wherever we are, and this is a fabulous example of just that. Local advocacy really does matter. What's Deepak's stance on copay caps? Well, it's pretty basic. We're for them. They are helpful, especially in the individual market. But as we'll talk about as we go here, they don't go far enough. They're not the panacea that solves the cost of insulin for people in the state of Colorado. Colorado is not okay at this point in time. None of the states that have passed it are okay at this point in time. So we're for them. They definitely help and they have a place in the market, but they are not the end all be all, as we'll talk about as we go through here. So one thing to note is they vary across the country. So, you got 50 different states. You can have 50 different copay cap bills, and they're all going to be slightly different. So majority of these caps only address insulin in their copays. And that was the first one, right? And these are evolving as we go. Some states distinguish between per prescription caps and total cost caps. So if you're on multiple daily injections and you're taking a long-acting insulin and a rapid-acting insulin, well, you're filling two prescriptions. So is the copay cap for both, or is that on a per prescription basis? So that can make the difference. If it's a $100 copay cap, which is what Colorado passed originally in 2019, that means you're paying actually $200 out of pocket. Well, we know from statistics that when a patient pays more than $75, they start they start falling off on their adherence in taking the drugs. So at $100, you're much closer to that 75. At $200, you're pretty far over that 75, and it's not going to be doing what you're hoping to do for the patients in that state. So distinguishing that's important. Colorado, as an example, is actually working this session to amend their bill that they passed just 2 years ago to clarify that they meant total cost. It doesn't matter how many prescriptions, you should only pay $100. So, as these things are going and evolving, we're seeing best practices being built into this. Other states establish maximums for supplies. So the $100 can be for both insulin and supplies, which would be great if you're on an insulin pump and you've got infusion sets, or you're on a CGM and you've got sensors and all of those things. Expanding the scope of these copay caps is really important. And so as we as advocates are seeing these bills start hitting in other states, now we're trying to get them to be beyond insulin. Let's really help the patient as we go, and really help the cost share issue, because as we all know on this call, diabetes is very expensive. And if you can't afford your medications, you can't afford your supplies, your control and your health is eminently impacted in a negative way. So what states have passed copay caps? Well, right now, 15 states have passed them, and you can see the varying levels. 2 of them are at $25, which is fantastic. Connecticut's one of those. 6 states are between 25 and $50. And most of those are at 50, but there's some 35s in there. 7 states are at 51 to 100. Again, most of those are at 100 or 99. So you can see that each of them are taking it a little bit differently, and we'll engage in all of them. And 21 of them are considering copay caps this year in their legislature. And we were tracking, that's a moving target. You see a disclaimer on there as of April 1, 2021. There are so many of these bills out there. This is a really, really hot topic. There were, at one point early in this year, I think in February, we started our state legislation tracking system, and we were looking at copay cap bills. There were over 37 bills that we were tracking across the country in this session, which is fantastic. I mean, it really says this is a hot topic. People are really paying attention to diabetes and the costs of impacting patients. And you know, many of those states, and this surprised me when I was looking at the list. Many of those states had multiple bills, where two or three, and one of them, I think it was Texas, had like 4 bills put forth that would have capped insulin, capped supplies, you know, again, gone back and tweaked it to clarify that, oh, it used to be, we meant not per prescription, but per month for whatever it was you were buying. So this is a really, really hot topic. And this is an area where advocates can make a difference because there's momentum. So when you see momentum like this happening across the country, this is a wave. And it's a purple wave. This is red and blue coming together. We want red and blue to come together. We want this whole map to turn purple, and you know, have a bipartisan cost reduction for people with diabetes so they can all afford their meds. But as we'll get into, it's not the end game. So what do copay caps not do? What do they not do in this? And first off, they don't apply to most insurance plans. So they're only able to regulate their own insurance plans within the states. They also don't fix the underlying market conditions causing drug, device, and supply prices to be unaffordable. So it's a limited impact of what they do. Now, the states can't fix underlying market conditions. That's got to be done at the federal level. The states can only do so much. So from the state's perspective, these are great bills. These are great things, but they're not the be all end all to solving the cost and the price of insulin and the cost of diabetes in this country. So what are state regulated plans? Because that's the only thing that are impacted. So that includes individual market exchanges in that state. So these are the Affordable Care Act individual exchanges within that state. And each state is standing up their own exchanges, and therefore the laws they pass will impact those. But that's a small portion of the population. Small group markets, again, limited to that state. That's another very small group of that population. And then state and public employee plans. And public employee plans could be local municipalities, city employees, state employees, you know, across that state. That's probably on that list there of the 3 items. That's probably the largest group on that list, although the individual market exchanges are growing as we go. But that's the limit to what a state regulated plan is. And it's a limit as to what a state copay cap can impact. If you're in that list, you are helped. And if you're not on that list, you're not. So who's left out in the cold? Well, that's roughly 90% of the people of the state. So, which is why this is not we can't shout from the mountaintops that we've solved the price of insulin in the state of Colorado or any of those states that had purple on it. But we've done a good thing. So don't get me wrong, we've done a good thing. But the uninsured are not impacted. If you're on Medicare, you're not impacted. If you're on an ERISA plan, which is most employer plans are ERISA plans. You're not impacted. That's half the country. Veterans and active military are not impacted by a state level copay cap. So again, we're helping, but we haven't solved the whole picture here. And so we clearly have more work to do. So this really, in order to get to those 90%, we've got to have some federal action taken. And there's not been a lot of federal action taken that's been meaningful at this stage. I will talk about the Medicare pilot program. So last year, this year, last open enrollment last fall, but effective January 1 of this year, Medicare had a pilot program, the senior savings model. And in that senior savings model, you can get insulin at $35 a month. That is a beautiful thing. Trust me, I've got sisters in Medicare who are paying $100 to $200 for insulin on Medicare. And 35 would be a lot better. And she picked the wrong plan. I'm saying that as that must opt into a participating plan. Do not take for granted that you are if your loved one is on Medicare, do not take for granted that, $35 insulin on Medicare, everybody's going to get this. They're not. You have to find the right plan. It's the senior savings model. You've got to find and select that correct plan that's going to offer $35 insulin. The good news is there's one of those in every state in the union. So that's great. The bad news is there are many other plans that don't offer it. And so don't take for granted that your friend, your loved one, yourself are going to just luck into and pick that. You've got to really go look for it. So I'm harping on this as we get to the next open enrollment in the fall. People need to be making the right picks. What else can the federal government do? Well, they can pass a federal copay cap bill. That would help. You pass a federal copay cap and that impacts the ERISA folks. That's half the country that you've stopped with. You've helped. That would be a major step forward. Preventive coverage for diabetes care. Now, preventive coverage for diabetes care, as I touched on at the very beginning, that would make diabetes care exempt from the deductible. You'd go right to your copay. Most people's copays are affordable in most of these plans. Some of them have co-insurance versus a copay, where in a co-insurance situation, you're paying a percentage of the cost versus $35, which is a fixed amount. Most copays are a fixed amount, a co-insurance. And then when you get into a co-insurance, you could be stuck with paying 30% of list price. So you could be well over $100 still if you're in a co-insurance. But making that preventive coverage and bypassing the deductible would really help a lot of people in this country. And that's something we should all be advocating for. The other thing that at the federal level is we should be advocating for rebate reform. Rebate reform is essential because it's what's driving the cost of these things as we go. I'm looking at and talking about Medicare prices, and I'm not sure you're seeing that on your screen now. As far as the question that Paul Madness is answering, and Paul, glad you're with us, and thanks for being on the call. And they're not allowed to ask for better prices on insulin. So he's quite correct. The government is not allowed. I'm going to clear the screen off. We are answering this question live. So we're not allowed to, the government is not allowed to negotiate directly with the drug companies. And that's been a head scratcher for a while. And how is it that the government, who you would think is all powerful, can't negotiate with the drug companies? And it's a complicated web that was specifically written into the law in 2003 when they passed the Medicare Part D law, where drug coverage became part of Medicare. One of the concessions, if you will, that happened during that that negotiation that became that law was that the government wasn't going to be able to negotiate. And what they did is they hired middlemen. So the government has hired pharmacy benefit managers to do that negotiation for them. And as a result of that, the pharmacy, and they also made the rebate process exempt from the RICO Act. So the rebate process, so in 2003, they tied their hands and said, we can't negotiate directly, and we're going to hire a middleman to do the negotiations for them, which is what everybody else in insurance is doing. All the major insurance companies hire a middleman to do that negotiation. So on the surface, that made some level of sense. But they then allowed the rebate game to be played by writing in the law an exemption from the RICO Act on that. So these rebates now are legal, and it drove up the price of insulin and many other drugs. And stay tuned for the June brown bag, because we're going to be talking in depth on rebate reform for those that really want to get nerd out on this stuff, because there's a lot to be spoken of. But this stuff is what's going to really ultimately solve this issue from a cost of diabetes care. And it's really important for us all to pay attention to. The state copay caps are still great. But what else can we do? If I click on here, maybe I can get this to move. There are other options and other fronts that we fight this battle on. And the first and the other main one is employers. So employers can adjust their own plans. Right now, there's far too many people, we call them underinsured, where they're facing list price for their drugs, their devices, their supplies, but they have insurance. How can that happen? And we call them underinsured. And we actually have, through DLC and Deepak, we have a educational program that we go to employers to educate them on what are you doing by making your patients and your participants and your employees, the folks that you should care about, pay full price. You're taking the highest risk people on your plan. A person with diabetes on a health plan is one of the highest risk people that are on a plan, because we have such the risk of of all the comorbidities, all of the complications. Those comorbidities, those complications, heart attack, stroke, kidney failure, blindness, amputation, all of those things are far, far, far more expensive than the cost of insulin, than the cost of a pump, the CGMs. They're far more expensive. But all too often, the focus is on cutting the cost of that drug and the cost of anything running through the pharmacy part of that benefit, and they don't care about what's happening on the major medical side of the benefit. Pharmacy side of the benefit costs for most people, and in my day job, I've been the plan administrator of a self-insured health plan for over 20 years. So I know what that payor side. The pharmacy side of a health plan is typically about 10 to 15% of the overall cost. 85 to 90% of the cost of a health plan is major medical side, which is really the hospitalization, the surgeries, all of that, those costs that are happening outside of the drug arena. But the folks that are trying to work on the drug side are not paying attention to it's the tail wagging the dog. So you look at an employer, and if they've designed their health plan, right, if they're, again, first dollar coverage, preventive care, you could be paying nothing. You could be at a low cost, very predictable copay, $25, or $360, or even $1,200. And everybody on this call knows this is real. These are just four distinctly different plan designs. If they're not passing through the rebates and they're not putting diabetes care as a preventive care pre the deductible, they're exposing people to list price. These employers will give away apples in the lunchroom. They will give away all kinds of things, but they will make you pay $1,200 for your insulin and train you to be non-compliant. So this is an area to get the message out. DLC has a webinar that we're doing with HR.com and JDRF. So we're in partnership with JDRF. We're doing one on June the 2nd through hr.com. If you are interested, please send us an email and we'll get you or get your HR folks in this. We've got some free passes that we'd love to share with that. So who's against a copay cap? I mean, this is mom and apple pie. Well, the insurance plans and the chambers of commerce are our opponents. When we're lobbying for a copay cap, and this is back at the state level, they will argue that these caps raise health insurance premiums, and nobody wants the premiums to rise. Well, they're rising anyway. And we know, and we have statistics that say the impact of passing through rebates, which is the same similar math here, would raise premiums less than 1%. It's minimal, it's minuscule. And that doesn't really, when you take that less than 1%, it doesn't really impact or take into account the savings by not having the heart attack, stroke, and the other things. I could argue that it's going to save the employer money. Obviously, these things don't affect insulin's list price because they really can't. And they don't hold pharma accountable because they really can't. But that's what we're up against when we're arguing. Again, our position on this is they're helpful. We're for them. If the federal level comes out and fixes it, they've only fixed it, and depending on how they write the law, we still may need them at the state level. So the state caps are helpful. We all just need to take as many bites out of this apple as we can. And while we're getting to the federal piece, I want to point out Deepak and DLC were part of a coalition and led a coalition of 12 national diabetes organizations to create a consensus statement on U.S. health reform. This is really fun reading if you really like to nerd out on health reform and what's going on out there. There are a lot of tangible ideas on how to improve the U.S. system commercially, Medicare, Medicaid. There's some really strong things on here, and everything we do as Deepak and as DLC, all of the positions we take are based in this consensus statement. So if you want to know why we're doing something, we can point to something in that consensus statement that's making that difference. So I encourage you to go to the DLC website and download that. Also, I'm going to wrap here in just 2 minutes. I'll be relatively on time. I encourage you to be a Deepak champion and get involved. If you are not registered on the Deepak website, diabetespack.com, please go and do that. You will get alerts when we send you alerts. Please click through. It takes seconds. And engage with your legislators, both at the state and the federal level. And we don't spam you. We give you things that are actionable. Warning, that's at the government pace. It's glacial. So you're not going to get, this is not spam. You're going to get very periodically an opportunity to take action. When it comes, take the action. Please take the action. And join us for events. Join us to the more brown bags, policy briefings. Follow us on social media. We'll try to keep everybody as engaged and as educated and up to date on things going on. There's a lot happening right now. You will see Deepak out there, and hopefully someday we can be face to face like these pictures. We look forward to Hill Days and things like that where we can actually be face to face. And thank you so much for being here. Julie, were there any questions or anything that I missed? You're muted.
Thanks, sorry. We just got a great question from Dan. Are you aware of any states exploring copay/co-insurance caps for insulin delivery systems, AKA pumps?
Dan, I'm not aware of the pumps as a cap. The legislation that we've tracked are caps on the supplies. So it would be your consumables in that pump. It's the it's the infusion sets and the cartridges that you would use within that pump. That's really what the scope of most of these copay caps are for, but they have not really addressed capping the price of a pump itself.
Yeah. Awesome. Yes, we are tracking supply caps, and those seem to be kind of the next wave of bills like this making their way through state houses. Thank you guys so much for attending. We'll send out a follow-up email with a link to the Facebook Live as well as a survey. We'd love to know what you thought and any issues you'd like to hear more about in the future. George mentioned that next month we'll be taking a look at rebate reform, but we'd love to get your suggestions. Thank you so much and hope that everyone has a great rest of their week.
Thanks, everybody.